Welcome to the debate. Our discussion today, it really springs from a deep dive into the U.S. healthcare system. Specifically, we're looking at the actual mechanisms required to break free from these just sky-high costs and inefficiencies. The core diagnosis presented in the material is that the standard technical fixes, like lifting the 1997 residency cap to get more doctors, or repealing the 85% medical loss ratio, well, they're just not enough on their own.
Right. That's because those fixes, they still operate inside what the source material calls the oligopoly trap. To really fix the system, you have to introduce actual competition. And that's why the material proposes restoring association health plans, or AHPs. It calls them the forbidden exit, which I think is a great term for it. This allows small businesses, individuals to finally bypass that integrated insurance and PBM oligopoly. It all comes together to form this necessary three-legged stool of reform. You've got supply, incentives, and competition.
And while that structural foundation is absolutely critical, the material brings up just a profoundly important challenge that really it sits at the center of our debate today, and that is the valley of death. This is not some theoretical problem. It's the immediate acute crisis that happens when you lose the fragile, hidden cross subsidies propping up the entire system right now, long before the benefits of competition can actually materialize.
The valley of death is real. I'll absolutely acknowledge the system's fragility. But our disagreement, I think, is on the transition strategy. The source material, it doesn't just diagnose the problem. It goes on to detail this very complex, very capital-intensive engineering plan involving a bridge fund and a fire station model to manage this whole transition.
Exactly. And I'm going to argue that this detailed transition strategy is a necessary, proactive, and frankly, a morally essential engineering step. We have to actively manage that destabilization to prevent a catastrophic collapse of crucial services and, to protect the most vulnerable people during that 3 to 5 year period it takes for competitive prices to really take hold. To reform this aggressively without a plan for managing the fallout is just reckless.
And I see it a bit differently. While I do acknowledge the risk, I worry that these complex temporary mechanisms are, an unnecessary diversion, a potential speed bump. They require massive political or philanthropic capital and a high degree of management complexity. It's a staggering effort. I believe the core structural reforms, if we implement them aggressively, will crush unit costs so quickly that relying on such extensive managed bridging might be an overestimation of the need, and it could actually slow down the ultimate goal of immediate drastic price reduction.
So my position is really rooted in intellectual honesty about the fragility of the status quo. If we implement this three-legged stool, we are by definition destroying the two hidden cross-subsidies that are currently holding the system together. We can't just pull the plug and, hope for a seamless transition. The evidence of risk here is it's two-layered, starting with the provider side. Right now, there's a systemic hospital subsidy at work. Rural hospitals overcharge for high-margin elective surgeries and routine care, and they use that inflated income to subsidize their money-losing, mandated emergency rooms and ICUs. If we restore competition, we let these focused factories, these transparent, high-volume specialty clinics enter the market, and they will immediately take all the cheap, profitable surgeries. The moment that happens, the entire financial rationale for those rural hospitals just collapses instantly, and that means services get shut down.
The logical bridge for this is what the material calls the fire station model. We have to stop pretending that core functions like emergency access are a for-profit business. Instead, we fund that essential public utility, the ER and ICU standby capacity, with a direct, transparent standby subsidy. This prevents the lights from going out in medically underserved areas. And then the second layer of risk is on the payer side, the insurance subsidy. The ACA markets, well, they rely on healthy people being overcharged to subsidize the high costs of the chronically ill. And this is crucial because ACA plans are mandated to cover pre-existing conditions. If those healthy people flee for cheaper, more efficient AHPs, using that forbidden exit, the ACA pools collapse immediately from adverse selection. The only people left are high-risk, high-cost, and their premiums just become mathematically impossible. So for that, we must deploy the bridge fund. This is a temporary federal safety net or maybe a philanthropic endowment that's required to underwrite the catastrophic risk for that 5% of high-risk patients who generate 50% of the costs. This fund is only needed for, say, 3 to 5 years, specifically to maintain insurer solvency until competition drives unit costs down dramatically. Without it, the vulnerable simply, well, they drowned.
That's a very compelling argument, but I would frame the urgency and the efficacy of that intervention differently. The emphasis for me has to remain squarely on the unparalleled power of market forces once they're actually unleashed by the three-legged stool. I agree the valley of death presents a risk, but focusing our political and capital energy on creating a massive temporary bridge fund and a new subsidy scheme for hospitals, it just requires immense political mobilization and institutional management. My concern isn't just the complexity, it's the opportunity cost. The source material really emphasizes restoring AHPs to bypass that oligopoly trap and repealing the MLR loophole that, facilitates the whole PBM shell game. We need to focus on those levers that bring immediate downward pressure on prices.
The moment competition really takes hold, the logic suggests that unit costs are dropping rapidly as these focused factories offer their lower prices. So if we assume the competition works as it's intended to, the duration and the scale of the required subsidy might be significantly overestimated. We should be laser-focused on unleashing that competition, allowing market dynamics to stabilize costs rapidly without setting up these extensive government-managed bridging mechanisms. The whole goal is to stop hiding taxes in insurance premiums, not create a new, albeit temporary, opaque funding mechanism that requires a staggering amount of capital to manage.
Let's deepen this on the rural hospital crisis. I see why you emphasize market forces, but let me offer a different perspective on the timeline and the management risk. The current cross-subsidy is just an unsustainable foundation for healthcare. If we unleash competition, allowing focused factories to offer cheap elective surgeries, the financial rationale for rural hospitals collapses. And it collapses immediately. The fire station model is the transparent, logical solution because it separates the public good, which is emergency access, from the business practice of elective surgeries. We pay a direct standby subsidy for that core public utility function, the guarantee that the ER lights stay on, and in exchange, they have to stop overcharging for routine care. This prevents the immediate critical service disruption that would otherwise leave whole communities with life-saving access.
But I question the administrative burden and the potential for moral hazard that's inherent in defining and managing that standby subsidy. I mean, how do we ensure that this guaranteed income stream doesn't just perpetuate inefficiency in hospitals that under true market pressure really should consolidate or restructure? Once the government is paying a fixed subsidy for standby capacity, the incentive to cut operational waste just shrinks substantially, unless that subsidy calculation is absolutely perfect. And that's a regulatory challenge that invites massive lobbying and, potential regulatory capture.
But the alternative is inefficiency. The alternative is the service gets shut down. If we wait for market pressure to force restructuring, we risk the lights going out in the ER while we wait for some complex merger to maybe materialize. The collapse happens way faster than the restructuring. The fire station model is a temporary transactional fix. We fund the standby capacity, and in return, the hospital has to agree to radical price transparency and open itself to competition on all other care. The efficiency pressure doesn't come from the regulator, it comes from the AHP demanding lower prices.
Okay, but this introduces a second challenge. Who defines medically necessary standby capacity? This new funding mechanism creates a huge new target for lobbying. Hospitals will argue that their definition of essential standby service requires more infrastructure, more staff, and therefore a larger subsidy. We risk diverting political energy away from enforcing the core competitive reforms and instead toward managing this perpetual negotiation over the size of a transitional subsidy.
We have to accept that we're trading one type of complexity for another. We are trading the opaque, morally dubious complexity of hidden cross-subsidies that are buried in your insurance premium for the transparent, managed complexity of a direct, accountable public utility payment. The priority has to be preventing the ethical catastrophe of service failure.
I agree on transparency, but the ultimate market fix is achieved when AHPs gain immediate leverage over hospitals. I mean, an AHP that represents 50,000 patients has the power to walk in and say, give us a fair price for all procedures, or we take our business elsewhere. That threat should force efficient restructuring much faster than setting up a new government funding mechanism. We need to focus on giving AHPs the tools to discipline providers, rather than stepping in to manage the funding of inefficient ones.
Okay, so if the fire station model addresses the provider side of the instability, we have to turn to the payer side, which faces a collapse that is just as catastrophic, the adverse selection triggered by that forbidden exit. So now we need to talk about the necessity of the high-risk patient bridge fund. This addresses the core ethical and practical crisis of adverse selection in the ACA markets. The vulnerable cannot be allowed to drown when healthy people flock to cheaper AHPs. The fund is designed specifically to underwrite the catastrophic risk for that 5% of high-risk patients. The crucial aspect is the financial bridge it provides. Just think about an expensive cardiac procedure. Today it might cost $100,000. Focused factories promise to do it for $15,000. But that price crash doesn't happen on day one. Existing insurers have to hold capital reserves against the $100,000 cost.
If the healthy pool of people leaves on day one, the insurer is left with insufficient reserves to cover the existing high-cost liabilities of the chronically ill. The bridge fund provides the necessary capital runway for 3 to 5 years while the unit costs are plummeting and their liabilities are shrinking.
I absolutely acknowledge the moral imperative and the immediate financial risk to the insurer's solvency. But I have to challenge the mechanism itself, particularly the staggering capital requirement. The source material emphasizes that we need capital, and that suggests either a massive temporary tax or a philanthropic endowment on the scale of, tens of billions of dollars. This is not a simple policy fix. It's a massive political and financial hurdle. So why introduce such a high barrier to entry and management complexity when the structural reforms themselves, the CAP, MLR, AHP, are designed specifically to make unit costs plummet? If we truly believe in the efficacy of the three-legged stool, shouldn't all our energy be focused on accelerating that price crash through every possible policy lever?
The capital needed for the bridge fund is so staggering that if that same political or philanthropic energy were instead directed at, say, aggressive tort reform or targeted deregulation, the price drop could be accelerated past the need for a bridge entirely.
That's an interesting point about acceleration, but you're assuming that competition's downward price pressure will materialize both rapidly and, universally across the board. What is your evidence that the price of complex cardiac care drops from $100,000 to $15,000 within that critical 3-year window before adverse selection drives every insurer holding high-risk patients into bankruptcy? Without the fund, the insurer either pulls out of the market entirely or the patient is faced with truly unpayable premiums, which defeats the entire purpose of the reform. The fund provides the necessary financial stability during the most volatile phase of this. It ensures existing liabilities are covered while new, cheaper capacity comes online. It's basically an insurance policy for the reform itself.
My concern is also about mission creep. We're being asked to set up this complex, multi-billion-dollar government-managed fund, even if it's temporary. Once a fund like that is established and subsidized patients become reliant on it, it rarely disappears, even after the unit costs have crashed. We risk trading one opaque cross-subsidy, the one hidden in the healthy person's premium, for another opaque, transitional mechanism that just becomes entrenched. And that shifts the focus away from true market efficiency and toward managing the subsidy structure.
I'm not so sure about that line of reasoning because the source material is very clear that this fund must be established with a definitive sunset provision. It has to be tied explicitly to achieving certain unit cost targets. We have to distinguish between a permanent entitlement and a temporary, sunsetting capital reserve designed to manage the acute volatility of a market transition. The bridge fund is designed to dissolve once the cost of care itself drops below a manageable threshold.
But the definition of that sunset threshold, that will be the next political battle. We need to be careful not to create a structure that incentivizes delaying the ultimate aggressive price reduction. If the solution relies on rapid competition to crush prices, then we should prioritize the levers that crush prices, like restoring AHPs,
which provide immediate leverage against the existing oligopoly.
But the bridge fund doesn't hinder competition. It enables the survival of the most vulnerable during the initial shockwave that competition creates. We have to manage the risk of systemic failure even as we champion market solutions. So to summarize my position, aggressive structural reform has to be paired with intellectual honesty about the fragility of the current cross-subsidies. The valley of death is real, and proactive, transparent measures like the bridge fund and the standby subsidy for essential services are necessary engineering steps. They keep the lights on and they protect the vulnerable while the market transforms. It's about ensuring that we manage a complex transition rather than just witnessing an ethical catastrophe.
And I would stress that while the risks are noted, and yes, must be planned for, the core focus has to remain on the speed and efficacy of the three-legged stool acting in unison, lifting the cap, repealing the MLR, and restoring AHPs. The complexity and staggering capital requirements of managing the transition must not overshadow the urgent need to dismantle the insurance oligopoly and the PBM Shell Game by allowing competition to discipline providers directly and, most importantly, rapidly.
At the end of the day, we both seek the same outcome, a functional, affordable healthcare market where unit costs are dramatically reduced.
Exactly. We simply differ on the acceptable level of intervention required to manage the inevitable short-term instability caused by unwinding decades of distorted incentives. The material really demonstrates that this kind of complexity often requires multiple perspectives to fully appreciate the path forward.